Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 374 of our pharmacotherapy series, which majors in fluid and electrolyte disorders. The next case reads, TMR, a 72-year-old woman, was admitted to the hospital with a 1-week history of increasing malaise, confusion, and decreased activity. TMR has a history of heart failure, hypertension, type 2 diabetes mellitus, and peptic ulcer disease. She was receiving hydrochlorothiazide, aluminum magnesium antacid, sucralfate, and insulin. She is febrile and in significant respiratory distress. ABG results at admission were a pH of 7.5. Partial pressure of oxygen of 42 mm of mercury. And partial pressure of carbon dioxide of 20 mm of mercury. Respiratory function continued to deteriorate, requiring intubation and mechanical ventilation. Serum electrolyte concentrations were as follows. Sodium levels of 128 milliequivalents per liter. Potassium levels of 3.6 milliequivalents per liter. Chloride levels of 96 milliequivalents per liter. Bicarbonate of 23 milliequivalents per liter. Glucose levels of 320 mg per deciliter. Phosphorus of 0.9 mg per deciliter. So my question to you reads, what may have contributed to the low serum phosphorus concentration in TMR? Hypophosphatemia can develop as the result of a phosphorus deficiency or secondary to a net flux of phosphorus out of the plasma compartment without a total body deficit. Moderate hypophosphatemia is defined as a serum phosphorus concentration of 1.0 to 2.5 mg per deciliter. A concentration of less than 1.0 mg per deciliter, as in TMR, is considered severe. The extent of hypophosphatemia may not be assessed accurately by a single plasma phosphorus concentration determination because of diurnal variation. Patients receiving large doses of mannitol may have pseudohypophosphatemia owing to the binding of mannitol with molybdate, which is used in the calorimetric assay for phosphorus. Hypophosphatemia is commonly caused by conditions that impair intestinal absorption, increase renal elimination, or shift phosphorus from the extracellular to the intracellular compartments. Hypophosphatemia secondary to low dietary phosphorus is exceedingly rare because phosphorus is ubiquitous. In addition, renal phosphorus excretion is reduced and intestinal phosphorus absorption is increased to prevent a deficiency state. Starvation in itself does not result in severe hypophosphatemia because the phosphorus content in plasma and muscles is often normal. Hypophosphatemia, however, can develop during refeeding with a high-calorie diet low in phosphorus. Therefore, hyperalimentation without phosphorus supplementation is likely to cause severe hypophosphatemia. Impaired phosphorus absorption secondary to malabsorptive conditions, prolonged nasogastric suction, and protracted vomiting can also result in hypophosphatemia. In TMR, the use of aluminum-containing and magnesium-containing antacids may further reduce phosphorus absorption. The antacids bind with endogenous and exogenous phosphorus in the GI tract and cause severe hypophosphatemia in patients with or without renal failure. In addition, TMR was taking sucralfate, which contains aluminum and can bind phosphorus in the GI tract. Similarly, iron preparations can bind phosphorus. Hyperglycemia-induced osmotic diuresis and diuretic use may have increased the renal loss of phosphorus in TMR. Other conditions associated with renal phosphorus wasting include renal tubular acidosis, hyperparathyroidism, hyperkalemia, hypomagnesemia, and extracellular volume expansion. None of these situations, however, was evident in TMR. Shifting of phosphorus into the intracellular compartment by glucose or insulin and profound respiratory alkalosis may also have contributed to TMR's hypophosphatemic state. The next question reads, what other conditions are commonly associated with hypophosphatemia? Diabetic ketoacidosis, chronic alcoholism, chronic obstructive airway disease, and extensive thermal burns are other conditions commonly associated with hypophosphatemia. They are characterized by a combination of factors that result in phosphate loss and intracellular phosphate use. In patients with diabetic ketoacidosis, metabolic acidosis enhances the movement of phosphate from the intracellular compartment to plasma, whereas the concurrent osmotic diuresis secondary to hyperglycemia increases the renal elimination of extracellular phosphate. The net result is a depletion of total body stores. Correction of the acidosis and administration of insulin then promotes the rapid uptake of phosphorus by tissues, and volume repletion dilutes the extracellular concentration. This sequence of events can ultimately lead to severe hypophosphatemia. The hypophosphatemia associated with chronic alcoholism and acute alcohol intoxication is also thought to be related to several factors, including reduced intestinal phosphorus absorption caused by vomiting, diarrhea, and antacid use, repeated acidosis that results in increased urinary phosphate excretion, and a shift of phosphorus into cells because of respiratory alkalosis. Renal phosphorus wasting can also result from hypomagnesemia or as a direct effect of alcohol. The next question reads, what are the signs and symptoms associated with hypophosphatemia? The clinical effects associated with chronic phosphorus depletion are often insidious and gradual in onset. In contrast, a rapid decline in plasma phosphorus concentrations results in sudden and serious organ dysfunction. Most of the effects can be attributed to impaired cellular energy stores and tissue hypoxia secondary to depletion of ATP or erythrocyte 2,3-diphosphoglycerate, Severe hypophosphatemia can result in generalized muscle weakness, confusion, paresthesias, seizures, and coma. In addition, reduced cardiac contractility, hypotension, respiratory failure, and rhabdomyolysis have been observed with acute severe hypophosphatemia. Chronic phosphorus depletion has been associated with decreased mentation, muscle weakness, osteomalacia, rickets, anorexia, dysphagia, cardiomyopathy, tachypnea, reduced sensitivity to insulin, and dysfunction of red blood cells, white blood cells, and platelets. Renal function is altered, as manifested by hypophosphaturia, hypercalciuria, hypermagnesiuria, bicarbonaturia, and glycosuria. TMR's decreased mentation, weakness, and respiratory failure are consistent with severe hypophosphatemia. The next question reads, how can phosphate depletion be assessed? Outline a treatment regimen that would effectively and safely correct the phosphorus deficit in TMR. How should her therapy be monitored? Phosphorus resides primarily in the intracellular space. The amount in the extracellular fluid is only a small percentage of the total body store. Because the patient's pH, blood glucose concentration, and insulin availability may affect phosphorus distribution, it is difficult to determine the magnitude of the phosphorus deficit based on the serum concentration alone. As discussed, a patient may have hypophosphatemia secondary to a rapid shift of phosphorus into the intracellular space without a total body deficit. The duration of the hypophosphatemia is often limited because it may be corrected by renal phosphorus conservation and oral intake of phosphorus-containing foods. Aside from serum phosphorus concentrations, urinary phosphorus excretion may be used to further assess the phosphorus deficit. Typically, renal phosphorus excretion is severely limited in patients with significant deficits. A phosphorus excretion of less than 100 mg per day, that is the fractional phosphorus excretion less than 10%, confirms appropriate renal phosphorus conservation when the serum phosphorus is less than 2 mg per deciliter. It also suggests a non-renal etiology, e.g., impaired GI absorption, or some type of internal redistribution, e.g., respiratory alkalosis. Prophylactic supplementation should be used in situations that predictably increase the risk for developing hypophosphatemia. These include patients who are receiving total parenteral nutrition or large doses of antacids for an extended period, alcoholic patients, and those with diabetic ketoacidosis. The specific treatment of hypophosphatemia depends on the presence of signs and symptoms, as well as the anticipated duration and severity of hypophosphatemia. In an asymptomatic patient with mild hypophosphatemia, that is 1.5 to 2.5 mg per deciliter, who has no evidence of phosphorus depletion, phosphorus supplementation is generally not necessary because the condition is usually self-limited. In other patients with mild and moderate hypophosphatemia, who have evidence of phosphorus deficit, oral supplementation is the safest and preferred mode of replacement. Skim or low-fat milk is a convenient source of phosphorus and calcium. Whole milk, because of its high fat content, can cause diarrhea if a large amount is consumed. Several oral phosphorus preparations can be used in patients who cannot tolerate milk products. When hypophosphatemia is severe, as in TMR, or when the patient is vomiting or unable to take oral medication, parenteral phosphorus replacement is needed. Several empiric regimens have been evaluated. IV administration of 0.08 to 0.5 mmol per kilogram body weight of phosphorus over the course of 4 to 12 hours is safe and effective in restoring the serum phosphorus concentration. More aggressive regimens, such as infusion over the course of 30 minutes to 2 hours, have also been suggested for critically ill and surgical patients. Parenteral phosphorus replacement should be stopped once the serum phosphorus concentration reaches 2.0 mg per deciliter and also when oral supplementation is started. In general, no more than 32 millimoles, that is, 1 gram of phosphorus, should be administered IV in a 24-hour period. Regardless of the regimen used, serum phosphorus, calcium, and magnesium concentrations should be monitored closely because IV phosphorus administration can induce hyperphosphatemia quite rapidly, as well as hypercalcemia and hypomagnesemia. Monitoring of urine phosphorus concentration also helps determine the adequacy of therapy. Metastatic soft tissue calcification, hypotension, and, depending on the preparation used, potassium, sodium, or volume overload may occur. This could be significant in patients such as TMR who have a history of heart failure and hypertension. Therefore, renal function and volume status should be monitored during therapy. Diarrhea, a common dose-related side effect of oral phosphorus replacement, can be minimized by diluting the supplement and slowly titrating the dose. Large doses can also result in metabolic acidosis. Phosphorus can be administered orally in doses of 30 to 60 millimoles per day, usually given in 2 to 4 divided doses to minimize GI adverse events, using any commercially available oral supplement, e.g., Fleet or Nutrafos. Fleet phosphor soda, dosed at 5 ml twice daily, delivers 40 millimoles per day of phosphorus. Skim milk, the preferred agent for diluting the supplement, contains approximately 7 millimoles of phosphorus per cup and provides calcium and potassium as well. In TMR, oral supplementation was not feasible because she had intermittent diarrhea and vomiting. Potassium phosphate 15 millimoles, providing 22 milliequivalents of potassium, was therefore infused IV in 250 milliliters of 0.45% saline over the course of 12 hours. The regimen was repeated once until the serum phosphorus concentration reached 2 mg per deciliter. Oral supplementation with Fleet phosphor soda then was begun by adding 1 teaspoonful twice daily to her enteral tube feeding. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arua, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 375.